Good afternoon, ladies and gentlemen. Obviously, we're competing with the wonderful winter weather, but thank you all for being here. Stragglers, please feel free to sit down. You know, when earlier today I was really concerned, even though I was just introduced by the voice of God, following an icon like Bill is no easy task. And actually, when he left, he said that to me because a number of times we've spoken together. He said, "I'm sorry I went before you." And I said to him, "I appreciate you being my opening act." And so, he's a wonderful guy, and really, much to his credit, he really is the poster child to what he was speaking about today, the whole concept of neuroplasticity and healthy aging and preventing cognitive decline. Because you think about it, I mean, every year he comes, and I have a chance to work with him during the year in other places, and the wisdom is just incredible. And as I heard him today, I thought, gosh, we need him more today than ever with, the challenges that we're facing, to have somebody that has that type of wisdom and that experience. Well, one of the things that a few years ago that came up when Joe Chiani was kind enough to ask me to join the team and assist him with this patient safety issue was that after my first year and I looked at what was going on, it was clear to me that this was really a global movement. And I remember speaking to Joe and said, "Joe, it's great we're going to save the nation, but as Tom Friedman has said, we're all interconnected. 7.5 billion of us are inhabiting this world that's flatter every day." And Joe was kind enough to agree, and we started talking about the globalness. And as I look through the audience today in this meeting, it's really representative of a global concern for this issue of patient safety. And a lot of it, of course, is because Joe had the vision to start here, but also saw that the information that we are developing here with all of the thought leaders contributing are going to benefit the nation. And as I look across the room, and I see so many of you I had the privilege to work with over the years from countries all over the EU. From Mexico, I saw the former health minister and some of his team are here and spent many days in Mexico. It's great to see that we have built those bridges into the patient safety movement, to welcome all thoughts, to welcome all of the thought leaders so that we can all profit and make the world and the health world we live in a safer place for all patients. Because of that, I'm really thrilled today to have the opportunity to introduce our next speaker, but also to have a few minutes when he's done to engage in a conversation with him about global issues and safety. Now, our next speaker, Minister of Parliament, I won't go over his whole CV because in his short life he has done many extraordinary things, from overseeing a U.S. Olympics, from being a champion for the disabled, a Minister of Parliament, and then, of course, I think he was a Minister of Culture as well, and then moves in to be a health minister for the United Kingdom. An extraordinary, extraordinary challenge. One of the challenges I used to have as Surgeon General of the United States with people who weren't that thoughtful would come to me and say, "Carmona, why don't you just get over all this health stuff? Just do what the Brits do." So today I'm going to ask Jeremy, what is it you do that my people want me to do? Because it's not that simple, and I'm sure he's going to tell you that as well. It's a really complex world, complex ideas, and as President Clinton pointed out, there are no simple solutions. But what we do need are thoughtful people who are willing to sit down and actually bridge across those differences in order so that we find solutions that benefit those fellow citizens that we have the privilege to serve, that we call patients. So, without further ado, I want to introduce the Secretary of State for Health Affairs for the United Kingdom, Jeremy Hunt. And I'd ask you to please give him a warm, warm United States welcome. I'll sit right there with you.
Thank you very much indeed, Richard, and thank you for describing my job as extraordinarily challenging. Sometimes in the UK, people say that being responsible for health is the most difficult job in government. But I always think it is the safest job in government because no one else wants it. And, it's a pleasure and a real privilege to be here. Thank you, Joe, for inviting me and to understand how the patient safety movement is taking off in the US and the leadership that you're showing. And I want to share with you a little bit about some of the things we're doing in the UK. Before I start, I need to start my talks these days with a quick health and safety check. And I just need to ask, are there any doctors here today? Excellent. Now, we've got some doctors. We've got Joe, who I think is an engineer. And, of course, I'm a politician. So I thought I might just tell you about the argument between the doctor, the engineer, and the politician as to which was most important for the future of humanity. And the doctors said, well, it's obviously us doctors, because without us, how could mankind have survived all these millennia? To which the engineer said, yes, but without us engineers, who would have created order out of the chaos? To which the politician smiled and said, yes, but who created the chaos? And this has been said to not a few holders of my office over the years, and it reminds me to approach the role with a great deal of humility. When I was appointed in 2012 by the then Prime Minister David Cameron, I knew really nothing about health policy. It's one of the curiosities of British democracy that people can get positions of great responsibility, not necessarily being qualified, something I know can never happen here. And I had to deal with a terrible tragedy, and I think this is something that happens in healthcare a lot. I had to deal with a hospital which a whole series of unspeakably cruel things had happened over a period of 4 years, and we'd had a big public inquiry, and within a few months of me arriving in the job, the report from this public inquiry landed on my desk. And the things that happened in this hospital were truly awful. There were people who were not given food and water, left to starve to death. There were people who, one woman described how her mother died after a really bad case of C. diff, and it was so bad that they refused to move the body until she was zipped up. The mother was zipped up in a body bag, and when this woman asked if she could say goodbye to her mother, she was told she couldn't because it was too dangerous, but she insisted, and the last she saw of her mother was the top of the body bag being unzipped and her mother's face poking out. There were people who had to take soiled sheets home to wash because the hospital wasn't washing dirty sheets. And these were really horrific things. And the first question I asked as a complete novice to the health world was very simply, how do I know this isn't happening in other hospitals? And the answer came back, well, we don't. And then I started asking some really distinguished doctors about this, and they were honest enough to say to me, well, we don't think it's as bad as this anywhere else, but we think there are probably pockets of it everywhere. And then I started talking about patient safety, and the chief executive of the NHS then said to me, you have to understand, Jeremy, that in healthcare, around 10% of patients are harmed. And he said it simply as a matter of fact. This is how it is, not just in the UK, but he said in countries all over the world. And I said, well, how many die? And he said, well, we can tell you the answer to that because we've actually had case note reviews, and it's about 3.6%. Again, the NHS in Britain is no different to other healthcare systems. We're middle of the pack. So I said, how many people is that? And in England, it turns out that we have 150 preventable deaths every week. That's 150 deaths where there's a 50% or more chance that that death could have been avoided. And then I met some remarkable people, and this really was the start. So if you look, these are the patient safety campaigners that I had the privilege to meet. So the lady on the right, Deborah Hazeldine, she's actually the lady who had to see her mother in the body bag. The lady at the top led the campaign for a public inquiry after her mother died of malnutrition at this hospital. The gentleman holding up a book, bottom right, James Titcombe, who I was emailing this morning actually, he lost his son Joshua in a hospital in the north of England where some terrible mistakes were made. And what was shocking was that it took him 6 years before the hospital would actually admit that something had gone wrong. And then the gentleman bottom left, I was just talking to an anaesthetist about issues to do with airways. Well, he lost his wife because in a hospital in Milton Keynes, they failed to give his wife a tracheotomy when she stopped breathing. And what was interesting about that was the fact that a nurse had spotted in the operating theatre that they might need a tracheotomy and had gone and got the equipment so that it was ready in case the surgeon asked for it. But the surgeons, in a classic case of human factors, were just focused on clearing the airway, and they didn't think about giving this man's wife the tracheotomy, and so as a result she died. And these are, extraordinary people, and they have inspired me so much with their stories, and here I've been privileged to meet people like Chris, who lost his son, people like Kieran, who lost his son to sepsis, and that drives their campaigning, and they are really ultimately the reason that we are all doing this. So then I asked myself, what do you do about this? And some of you may be thinking, well, perhaps it's a bit easier for a British Secretary of State because we have a National Health Service. Isn't it just a question of pulling a lever, pressing a button? But he didn't say it this morning, but President Clinton once said something very wise about politics. He said, politics is like working in a graveyard. There are lots of people underneath you, but they're not necessarily listening. And in fact, it's not just that they're not listening. Sometimes they absolutely don't want to listen. This is the strike that I had last year when I decided to change the contracts to deal with the fact that our weekend mortality rates are 15% higher than our weekday mortality rates. That placard saying "Hunt must go" is one of the more polite ones. If you think about what my surname could rhyme with. But the truth is that these young doctors are all remarkable people, totally committed to their profession, and I disagree with them about this contract, but I have huge respect for what they do, and the NHS, as healthcare systems all over the world, is under a huge amount of pressure at the moment. And everyone shares a passion to do things better than we do at the moment. But when we looked into it, let me just go back. When we looked into the problems that we were facing with respect to patient safety, what we found was that it wasn't a lack of good clinical practice that was the issue. It was the failure to share clinical practice. Now, I flew over from London earlier this week, and I looked up on Wikipedia, and the first transatlantic flight was 98 years ago. Now, if you'd flown in those days, the first thing you'd have said is make sure you get a good pilot. But now when you're flying from London to New York, you don't say that. You just take it for granted that the airline industry spreads good practice across the whole industry, and that the right things will happen because the message will be spread out. If you get cancer, the first thing people say to you is, have you got a good doctor? Because the public know that in healthcare we have not learnt how to spread good practice in the way that we have in many, many other industries. And that is the fundamental difference. So if we're going to change that, it's not about command or control, it's not about targets, it's not about telling people how things have to happen. It's about creating a culture of openness and learning and transparency. And the phrase that I like to use in the UK is not transparency, but intelligent transparency, because there are two types of transparency. There's the transparency that creates suspicion and worry, and people think it's about naming and shaming. And there's the transparency that is the spur to learning and driven by peer review and creating a culture of continuous improvement. So we embarked 3.5 years ago in, I think, what is the biggest program of intelligent transparency of any healthcare system in the world. And we started with our hospitals, and we employed one of our top doctors to send teams of doctors and nurses around every hospital in the country and inspect them for quality and safety. And this is a huge process. Sometimes 50 people will go on an inspection. They'll be on site for 3 days. But it is very much driven by peer review. And we ended up this autumn that we've just had, completing the process. And these are the real results. Now, the key here is, this is just a selection, but the key here is that we asked this inspection process to grade every hospital with one of 4 grades: outstanding, good, requires improvement, or inadequate. And then, of course, there's a huge amount under the inspection report, so the emergency department, the maternity department, they all get those same gradings, and then there's a big report, several hundred pages, about the things that they've found out. But by keeping it really simple in terms of the overall grading, it becomes something that the public can understand as well as the profession. And the results were very dramatic. We found that over 10% of hospitals got the bottom grading inadequate and had to be put into special measures. And this was a pretty traumatic thing for the staff in those hospitals. Of course, it's not the staff's fault. It is invariably about the leadership in those hospitals rather than the commitment of individual clinicians. What we did, if I give you one example, there was a hospital in Slough called Wexham Park where the care was unsafe, and they were put into special measures. It was so unsafe that in staff surveys, less than half the staff would recommend the care in their own hospital for their own family or friends, because we asked them that question. They went into special measures, the management was changed, huge transformation in the quality of clinical care over an 18-month intensive period, and they got a good rating. More than 2/3 of the staff then said they would recommend the care they received, and the morale in that hospital shot up. Over that same 3.5-year period, we've seen, if you take the 4 most common hospital-acquired harms, pressure ulcers, avoidable falls, urinary tract infections, and VTE, they went down by about 1/3. Over 6 years, so a little bit longer, MRSA and C. diff have gone down by 1/2. And patients say that their care has never been safer, and they've never been treated with more dignity and respect. And all this against a background of a huge amount of pressure on the front line. So, the pressures of the aging population, of increasing expectations. Despite all of that, we managed to get these improvements in safety and quality. But then we began to realize it's not just about hospitals, because there's all sorts of care that goes across multiple providers. And so we then went a step further 2 years ago, and we said, well, we're actually going to take disease areas and grade the quality of care by geographical area. So we started with mental health, and we last year published by region the same kind of system of ratings. And this is, again, been incredibly helpful. So if you take the list in front of you, which is just a selection of areas, so you have Liverpool, which needs improvement, Norwich, which really needs improvement. But thanks to this system, they can actually look at the areas of the country that are doing best in mental health, like Bath and North East Somerset or Cannock Chase, And so you start to create the process of peer review and self-driven improvement. That means that you can eliminate that unwarranted variation. And then we started thinking that there's something else that we need to do. And this is the most challenging thing of all, and it's happening this year, which is we realized that if you asked hospitals, we know that there's 150 avoidable deaths every week. But if you asked an individual hospital how many of those are in your hospital, more often than not, they can't tell you. So we are changing the law to require every hospital to publish every quarter what they believe the number of preventable deaths in their hospital was over the previous 3 months. And this July, for the first time, we'll see that. Now, I think we're going to be the first country in the world to do that. Now, I've just used dummy names for these hospitals here, but this is the kind of data that we'll be able to see about English hospitals. And this is going to be very challenging because it can't be a league table, because you may well find that the hospitals that have the highest reported avoidable deaths are the ones with the most open cultures and the most developed reporting networks. So it's very important when we start to do this that we don't penalize people who get the highest scores. But my intention as Health Secretary is that I want to require every board of every hospital to sit down once a quarter and agree what that number is and explain to us if it's lower than the national average of 3.6%, why that is, and what they're doing, most importantly of all, to learn from this process. So that's the transparency program. But then we started looking at clinical practice, and we thought there's something else. Every week in the NHS, we have 2 cases of brain-injured children at birth caused by medical error. And typically what happens in these cases is that the family takes legal action. It takes an average of 11 years for the courts to decide. And remember, these families are having to cope with the huge shock of bringing up a severely disabled child and all the pressures. And for the most severe neurological injuries, that will be a settlement of around £6 million. This is causing a huge explosion in the litigation bill that I'm having to pay out of the budget, but it's also causing untold human misery. And of course, when those things happen, there is a second victim, and that is the doctor or nurse who was responsible, because it is incredibly traumatic for people who've gone into their profession to try and save lives to have to accept that maybe they made a mistake. And we make it nearly impossible for doctors in those situations to do the one thing that they want to do more than anything else, which is to sit down openly and honestly and say what happened, learn from the mistakes, and make sure they can spread that message to everyone else in their hospital and everyone else in the country. Because they're worried about being sued, they're worried about being struck off, they're worried about the reputation of their hospital, they're worried they could be made a scapegoat, all these things. And so we are going to pass a law that mimics what happens in the air industry. Here you have the National Aviation Safety Board, or National Transportation Safety Board, where there is legal protection when there's an investigation after an air crash. The airline industry went through this 30 years ago when they realized that just firing pilots who made mistakes was not the way to improve airline safety. We need to go on that journey, so we are going to give legal protection for doctors and nurses who speak openly and honestly. And that will be another step in this journey. I just want to finish by thanking some very brave and wonderful Americans who have helped on this journey. Don Berwick, who I know is well known to all of you, did a fantastic job in his report on patient safety in the NHS, which we've learnt a huge amount from. We also worked very closely with Gary Kaplan, the Chief Executive of Virginia Mason Hospital. And you know, I want to add all of you, Joe, in the patient safety movement to my list of inspiring Americans when I look at the incredible work that you're doing. You sent me a letter and I didn't really know about you. I thought I'm going to come over and check it out. And you know what I want to say is this is the time to go global, and London is the place to come. We have fantastic weather. Come over. And now you've got Bill Clinton as your global patron. We would love to host your first ever global patient safety movement conference. But Gary Kaplan, I see that Virginia Mason Institute is one of your sponsors. He alerted me to something I hadn't understood about the patient safety movement, which is that when everyone is worrying about the use of resources, actually making mistakes is one of the most expensive things you can do. And this isn't about whether you can afford safe care, it's about whether you can afford not to have safe care. If you take orthopedic infections, we know in England our best hospitals infect 1 in 500 patients. Our worst ones, it's 1 in 20 patients. Extraordinary variation. But each time we have an orthopedic infection, it costs us £100,000 to put it right. So as Gary says, the path to safer care is the path to lower cost. There's an economic imperative as well as a moral imperative. But I just want to finish with a reflection on this moral imperative. You've got the signs out there with the study from Johns Hopkins that says that in the US there's 250,000 preventable deaths every year. And one of the signs says that it puts medical error as the 3rd biggest killer after cancer and heart disease. But there is a difference, because we are waiting for scientists to come up with a cure for cancer, and I hope they will, but it hasn't happened yet. With heart disease, there are advances in medicine, but also changes in lifestyle that we're going to need to crack it. Medical error is something we can sort out now. We can do this right away, and we have the responsibility to do it. And when you put effort as an organization or as an individual into minimizing the harm that comes to the patients who are in your responsibility, you are saying that is because the patient in front of me matters as much as my mother or my father or my brother or my sister or my son or my daughter. That patient is an individual. And that's what medical ethics is all about. Thank you very much.
Fantastic presentation, Jeremy, and it seems that we have a lot in common. Other than the weather, I think we do have a lot in common. Many of the initiatives that you are speaking of are ones that we're being challenged with. As you know, in a democracy, often it is difficult to move things forward, and sometimes you wish for a benevolent dictator to get something done. One of the things that you had mentioned as you look at your hospitals and the great disparity between hospitals and practice. In our country, one of the things we started to look at is something called the social determinants of health. And by zip code now, we can largely predict outcomes. Are you using that type of an approach as well?
We absolutely are. And we know that this is particularly relevant on the obesity agenda. So that is why when you start talking about the definition of preventable, sometimes it's not a completely static target, because of course you can do something about the social determinants of health, but it is a bigger change than sorting out your procedures for preventing orthopedic infections. But it is a very important one. We know that our life expectancy in the UK varies across the country. If you take the centre of London, where I live in the borough of Westminster, and you take Hackney, where I was responsible for the London 2012 Olympics, life expectancy is 9 years less in Hackney than it is in Westminster. We used to say for every one stop of the Central Line, the tube, you go down, life expectancy goes down by a year. But that is pretty shaming for a modern democracy that you have those. And so I think we have a very similar debate to you. I'd say that what I find interesting is, although our healthcare systems are very different, There is a huge amount we have to gain by working together. I strongly support Senator Whitehouse's plans for a patient safety bill, because I think that is going to be something that makes a big...
Yes.
And in some ways, it's easier for us to get that transparency in the UK because I have levers to require hospitals to collect and publish data, which are more difficult to do in the US, at least at the federal level. But what you have in the US is extraordinary innovation. And that's what the incredible thing, I mean, with, I think sometimes in terms of healthcare systems, you have the best of the world, and if you don't mind me saying, sometimes the worst in the world, but you do have the most incredible innovation in this system. And when it comes to the lean manufacturing techniques that I see at Virginia Mason or Intermountain or Group Health, it's really, really impressive. And I think the other thing that we haven't touched on this afternoon is the nexus between technology and IT change and patient safety, which gives us an opportunity to dramatically improve patient safety, and that's something where I think US leadership is extraordinary.
Let me ask you another question. We spend a lot of time in our discussions about retooling our infrastructure to be able to access information that is being able to be utilized for some predictive ability to be able to reduce the morbidity and mortality associated with challenges that we're speaking of today about preventing. But as we look at doing that, as you say, you have levers that you can push. Our levers are kind of rusted shut a lot, and it's tough to free it up. And I think we have the same problem, but we have some challenges maybe that you don't have in being able to move this forward. For instance, as we look at advertising in our nation, every hospital claims to be the best hospital. Every doctor is the best doctor. I'm a recovering surgeon, okay? So when I practice, I say that because when you ask a surgeon in the United States to name the best 3 surgeons in the world, they always have trouble naming the other 2. See? And so those are kind of the headwinds we may be having because every hospital is the best, every doctor's the best, and so on. And prior to being a doc, I was a nurse. So earlier on, I would love the comments of the nurses here who spoke about, because the nurses really are that platform that we work on. They're at the bedside 7/24. How do we overcome some of those challenges?
Well, I think you do have to dive in at the deep end and start sharing data. But, and this is where I think you may find that you do need to have a law. And I'm not saying that you're going to be able to go the whole way that we've gone and actually have an overall grading system for hospitals. But you could require hospitals to supply information in very specific areas like preventable deaths, like sepsis, and that I think is a very, very good start in the process, although you always have to be careful when you're requiring data to be supplied that people don't game the data, which of course is, there can be an incentive to do if people are thinking about their own reputations. We are now looking at what we can do at much more at an individual surgeon or doctor level. It's really interesting to me when I look at somewhere like Kaiser Permanente that their method for improving quality and safety isn't through financial incentives. I think less than 10% of a physician's remuneration in Kaiser actually comes from anything that's performance related. The way they drive up performance is by sharing data about clinical outcomes. And I think to do that, you have to create trust. So what we are now looking in general practice in the UK is, can we collect data? Can we collect data from surgeons about individual performance, which we commit we won't publish, but we will collect it and then make sure that you and your peers can see this data and learn from it and see who the outliers are. And I think both in the UK and the US, fantastic progress has been made in heart surgery, where the mortality data is collected and disseminated. And the interesting thing you find is surgeons are naturally competitive, as you just said.
I think?
I think they are. And what that means is that you actually don't have to do very much other than show people the hard data. And if someone is an outlier, if someone's mortality rate is significantly higher than their peers, they are going to work night and day to try and improve that. Right. And that seems to be the most positive thing to do.
Thanks, and we agree. We're playing with all of those things in the United States now, but it's still a challenge. One of the other areas that I'm interested in your opinion is the issue of the patient themselves. What can we do to educate and empower the patient to be able to be participatory in this process so that if you're my doctor and I come to you, I can ask you the right questions that will drive demand for good information and really free the docs up then. I mean, so if we have a culture that's all-encompassing and every patient is empowered in a culturally competent, health-literate manner, understands what we're looking for, and they help us to drive, I think we'd have a more perfect system.
I totally agree. I was privileged a couple of years ago to meet Eric Topol in California and read his inspiring book, The Patient Will See You Now. And this seems to me to be the big cultural change that is going to happen, which is patients getting control of their own healthcare destiny, particularly people with multiple long-term conditions, chronic conditions, who we know will get better outcomes if they take responsibility for their own treatment. And so I think this is a really, really important and interesting change. And this is one, I think, where technology can make a huge difference. If people were able to see their medical records on their iPhone, and what we're doing this year from September is we're going to make sure that every patient in the whole of England can access their medical record online. Now, we don't have a great queue of patients who are saying we want to access our medical record, but what we are expecting to happen is that people will download apps, a diabetes app, for example, and that app will have the right to quiz your medical records. So you then have the opportunity, for example, if you wear a Fitbit, to link that in, and with your consent, your physician can then see the exercise you're taking, and you start to have a much more holistic conversation with people. So I think that is a really profound change. I totally agree with you, Richard. I think this is a very positive thing for doctors. I think there were, in the early days, people worried it could be a threat if people are able to Google their conditions and learn. But actually, if people understand more, I think they're more likely to adhere to their treatment plans. This is something, I think, where the US movement to say that actually patients have a right to access their own records is something where you've led the world on and will make a huge difference. And I think you will be a pioneer in this area.
And you know, to put it further into perspective, you know, when I was in office, it really plagued me. We're spending about 19% of our gross domestic product on what we call health care. It's actually sick care. And when we look at the dollars, which is about $3 trillion, the fact is about 75 cents to 80 cents of every dollar are spent on chronic diseases and complications that are all preventable. And so we keep chasing our tail. The cost of care continues to go up. We try and improve efficiency and effectiveness within our infrastructure, just as you're doing. But the bottom line is the cost of care and disease burden is going to continue to go up unless we start addressing some of these preventable issues. And there are many.
Absolutely. And we are big fans of the accountable care organization model. And we have a plan over the next 10 years to essentially move the NHS in England to 44 accountable care organizations. And I would just pick up actually on, I think, a really good example, and I know this is something you're going to come to this afternoon, a really good example of why that is true is the discussions that you're going to be having later on mental health that were actually raised by President Clinton, because I think that is a perfect example of something where if you don't look at the whole picture, you're unlikely to focus on anything other than relieving the immediate sickness.
Yes.
And if people have a mental health condition, there are still many people who don't understand how many mental health conditions are curable. You can actually get a total cure for certainly some of the less severe forms of depression. We know around 50% of the time, often through talking therapies and not through medication. Well, combined with a program to deal with physical conditions, you have a chance to focus on wellness and not sickness. It's a big cultural change, but I think we're going to bankrupt all of our systems, us with our taxpayer-funded system, you with your privately funded system. We all face, you know, the same really severe financial constraints, and that's why I think we have to go down this route.
Well, we are in a world of infinite needs and finite resources, and when I was SG here in our nation, after a number of years, I always, in speaking with my senior staff, said, you know, the one degree that I really need to be a more effective health leader is that of an anthropologist. Because ultimately it all comes down to culture and figuring out how to deliver messages which resonate with the population to really do one thing only, effect sustainable behavioral change. And I think without that, everything we're trying to do, everything that Joe's been driving and the team, we won't be able to capture the health we want and the economic benefit we want unless we have that population that's engaged with us on this journey.
I think that's right. And you know, when you talk to the futurologists in Silicon Valley, they start saying that you know, within a decade, we won't be going to doctors for diagnosis because we'll be doing a monthly blood test at home that will be possibly not just comparing our blood samples to our own previous samples, but to other population groups. And this will be, I think, part of a big change in people taking ownership of their own health destiny. And I think it's a wholly healthy thing. I'm someone who believes that healthcare innovation will change humanity as dramatically in the next 25 years as the internet has in the last 25 years. And the only bit of good news in terms of pressure on healthcare systems and budgets that I heard was some research that came out of some US university that said that our life expectancy will not increase beyond 115. And that was a huge sigh of relief for me because otherwise it's just not going to stop.
Well, when I was in office and I would speak with the actuaries at Social Security, and they would always rib me and say, hey, Carmona, you got to get off this path of, you know, live forever because we can't afford it. They said it just gets too expensive. You keep adding years on and we can't afford it. And so it was always poking me in the side. But, you know, when we look at, in 1900, our life expectancy in this country was about 48 years old. You fast forward a little over a century, we're pushing almost twice that, pushing 80 years old, depending on where you are in the world. Yet in our country, depending on which metrics you look at, we're ranked between about 25th and 50th in WHO metrics as far as vaccinations, longevity, quality of life, all of these type of metrics. So clearly, spending twice as much money as you all do in the UK doesn't help us.
I think if you talk to any British doctors, they might say, could you spend a little bit more? But I think the longevity thing is interesting. I mean, I think in the case of the US, you have some of the very best healthcare in the world here, but you also have a lot of variation, which is why when those metrics are published, you tend to be in the middle of the tables. I mean, our academics in Britain say that we're living for approximately every decade that we live, our life expectancy goes up by 2 to 3 years. If you do the maths, that actually means that for every 24 hours that we live, our life expectancy goes up by 5 hours. So when you're tucked up in bed tonight at midnight, that's an extra 5 hours at the end of our life. And I think the responsibility for my generation of politicians is that extra, those extra hours, days, months, years at the end of our lives, are they going to be a period that we look forward to or a period that we dread?
Well, I think the term is that we all want to live longer but younger as we go forward. And certainly we haven't, as a nation, dealt well with the end-of-life issues. As you know, we spend exorbitant amounts of money at the end of life. Often there are complications there too. IVs putting in, Swan-Ganz catheters, medication errors, and so on, in a 90-year-old person who may have a pneumonia. And yet, what I think is most illustrative as you travel the world and you see that there's a better understanding of the circle of life. That, you know, grandma and grandpa don't go to an ICU. In fact, in many communities, there's no such thing as a nursing home in many of the more primitive societies, which I thought was always ironic because they're a lot more advanced thinking than we are. They celebrate that circle of life, not at a high cost, but at a very low cost with no complications.
Well, I totally agree with you. And I think this is something which we aren't going to be able to solve in healthcare on our own, because actually there's a big societal change that we need. We have huge pressure in what we call our social care system, which is the care system designed to look after people on low incomes who need that extra care, particularly towards the end of our lives. And what is very striking is if you look at some of the Mediterranean countries like Italy and Spain, they have protected better their family structures. And so you see a lot more older people living with their children. And frankly, that's what we'd all want. But in Britain and America, we've allowed our societies to become very atomized, people living hundreds of miles away from their own parents. In China, they've passed a law where you can actually get punished for neglect of your own parents. I don't think that would sell politically in either of our countries. But I think we have to recognize our own responsibilities. And I think this is going to be something that confronts all of us.
It is. These are great societal challenges as we move forward. On the other hand, relating to what Bill Clinton was speaking about this morning, with challenging the mind and preventing cognitive decline as we age, which is what he was talking about, the science of neuroplasticity, epigenetics, and so on. When you look at Dan Buettner's work on the blue zones, which is what you were speaking about, the one thing that we missed for many years with diet, exercise, and all of those things to reduce risk, keep costs down, was the social interconnectedness. That's what keeps the networks alive. Because once they put you in a corner and nobody sees you, nobody touches you, nobody hugs you anymore, you start to disappear from society. And you do end up costing more, and you will have complications because of that.
That's right. There's a great TED talk on how to live until you're 100, which I recommend. But they look at in an anthropological way at the communities across the world who have higher life expectancy than you would expect. And one of the common themes is the strength of the communities people live in. I think diet is important, but it was about quantity rather than what you actually eat. Moderate exercise was important. But then, as we're running out of time, I'll just say something else. The other thing they talked about, which was very closely linked to longevity, was having a sense of purpose in your life.
That's right.
It's what Bill Clinton said. It's what mental health professionals talk as a really important and smart way to boost people's well-being, associating yourself with something bigger than yourself, than your immediate desires. And if I could just say, I think that's what the patient safety movement is all about, and that's why I think the work you're doing is absolutely wonderful.
And so, Jeremy, in your opening remarks, I'm happy that you took credit for politicians in chaos. And I'd ask you then, with that in mind, how do we get out of that cycle? What's the advice you could give us in the United States, knowing our system as well? You've met with our colleagues, Don Berwick, Eric Topol, who was a resident classmate of mine. I mean, far-thinking thinkers. Where can we do better? What can we tell Joe and the safety movement as well that we can incorporate some of the practice that you have found to be advantageous?
Well, I'll make just a general comment about politics because we've had our own shocks in the last year with Brexit, and I think that the lesson that we have to draw from this is that we, as a political class, have failed to communicate with large chunks of our own electorate. We are, two of the oldest democracies in the world, and in the end, it's because I'm a Democrat that I'm respecting the decision to leave the EU, even though that wasn't my own preference. But we have to be better at finding a language that reaches people who aren't that interested in politics and for whom it isn't a big part of their life. I think it's interesting listening to President Clinton. This was someone who, when he was president, was brilliant at connecting with all sorts of people. You had Reagan here, just to be bipartisan about it, who was equally brilliant at doing that as well. And I think if we lose that ability to connect with people, then we will find it harder to argue for rational, evidence-based politics, which is, I think, what we all want. And I think that's really what the wake-up call of 2016 is.
I think it's a great point that when I see the similarities with President Clinton and President Reagan, they built bridges, not walls. They connected people. And because of that, we were all better off, irrespective of the politics. And as was pointed out time and time again, I think Senator Whitehouse spoke of it earlier, is that we have to figure out how to get past those issues because, as I used to say as SG, nobody ever came, when I was a trauma surgeon, nobody ever came into the trauma room with a gunshot wound asking for a Republican trauma surgeon or a Democratic trauma surgeon, okay? They want to get saved. And when I would speak to our colleagues up on the Hill, and they're arguing vociferously about veterans issues, about the military, I'd say, when I was a young soldier in combat, and my guys died in combat, when I went to those funerals, I never knew what party they belonged to. Because we were downrange as Americans. We weren't there as Republicans or Democrats, to your point. And to me, I think that is the point. We need more voices of moderation. And I think that this initiative that Joe founded and has allowed us to participate in, I think should be nonpartisan. Because it really makes no difference which side of the aisle you're on. We're all going to be affected by these issues. And we should be able to join hands and address the hundreds and hundreds of thousands of people that die needlessly, your country, mine, and the rest of the world, because this is a global issue. So, ladies and gentlemen, please thank me for the great presentation by our Prime Minister of Health from the UK. Thank you, gentlemen. It's a pleasure.
Thank you very much indeed.